Thank goodness there's a lot of other things in this space. So there are a lot of drugs that are being developed for patients that either relapse after a transplant or are ineligible for a transplant or cannot get into remission prior to transplant. There recently was the FDA approval of a combination of drugs, bendamustine rituximab plus polatuzumab. This is an anti-CD79 antibody, and this is also approved in patients with relapsed large cell lymphoma. There are ongoing trials with many other targeted drugs, drugs that are targeting different cell surface antigens. We have several combination trials which are ongoing, looking at the potential benefit of drugs like venetoclax, other next generation immunomodulatory drugs. And hopefully, as these drugs continue, as these trials continue to progress, we'll see other good options for patients with relapsed large cell lymphoma. I think one of the most exciting things to come out in the last couple decades for large cell lymphoma is CAR T cells. And the reason they're so exciting is they use a very novel mechanism to target the relapsed large cell lymphoma. This is a mechanism, or I should say an approach, that has been very successful in children with relapsed B-cell leukemias, and is also being used in many other different types of B-cell malignancies. And essentially what we do is take a patient's own T cells and we train them in the lab to recognize cancer cells. These T cells are then reinfused into a patient where they expand and then go on the attack. And what happens is these T cells then find, recognize, and kill malignant B cells within the patient. Now, these approaches, using CAR T cells in relapsed large cell lymphoma, have been associated with long-term or durable remissions in anywhere between 30 to 50% of patients. And many of these patients had failed a prior autologous stem cell transplant or were ineligible for stem cell transplant. So again, the most exciting thing is not just how they work, but these drugs are working very well, potentially curing patient populations where we did not have a lot of options previously. Now, these drugs are associated with side effects, so they are not without risk. Many times patients can develop very severe cytokine release syndrome. This is a syndrome which can lead to multi-organ damage. It can sometimes lead to very severe neurologic changes in the patients, everything from seizures to patients having respiratory failure to having confusion. Now, unfortunately, at least today, we do not have a good way to predict who or when these patients develop side effects. So many of these patients are watched very closely for the first 2 weeks after receiving CAR T cells. It's quite uncommon to have late side effects with CAR T cells, with the exception of sometimes some cytopenias. So if patients make it the first 2 weeks and they have a remission, especially the complete remission, there's many times a very good chance that they can maintain a durable remission or a cure. So very exciting times. There are several next generation CAR T cells being developed, and hopefully some of these next generation drugs will result in a very, or I should say a more favorable side effect profile and potentially even higher complete response rates. Currently, CAR T cells are approved for patients that are relapsing after autologous stem cell transplant. I think this is the place where most clinicians are using them. We are now seeing trials which are ongoing, looking at CAR T cells before transplant. These are very interesting trials where they're randomizing patients to receive CAR T cell or salvage chemotherapy followed by stem cell transplant. So I think in the future we may actually see CAR T cells moving into earlier lines of therapy. There are a couple trials looking at CAR T cells in the front line in patients who are beginning to fail treatment early or who have PET scans which are not in complete remission early. And I think this really is the future of CAR Ts. We're going to see them move into different spaces, potentially into earlier lines of therapy. And as we see some of the next generation CAR T cells emerge, we may see them also used in other types of malignancies, potentially some of the low-grade lymphomas and other types of leukemias. So I think we're just beginning to see where CAR T cells will be used across many different B-cell cancers. In my own practice, I generally use CAR T cells, I should say commercial CAR T cells, in patients who I cannot get into remission prior to stem cell transplant. So I think the ideal patient would be a young, fairly fit patient who gets, for example, rice chemotherapy, potentially another chemotherapy as salvage prior to autologous stem cell transplant, and does not achieve a remission. This is a great candidate for CAR T-cell because many of these patients, again, as I mentioned, will achieve a complete remission, and some of them will achieve a complete remission that's durable. The other population of patients who I'm using CAR T-cells in my own practice are patients who fail autologous stem cell transplant and have a good performance status. And this is really the ideal candidate as well for CAR T-cells, patients who are otherwise healthy, failed autologous stem cell transplant, and I'm trying to achieve a durable remission.